I will argue with you, Steve, and I'm pretty sure just looking at your face the way this is going to go. We should be preventing disease that causes terrible morbidity and mortality, but I don't understand why we would continue just to stop disease. And therein lies the problem with the flu, because the general public doesn't know anybody that died with the flu. When COVID started to come on board, it was even worse because people didn't even believe COVID existed, and we were proposing to vaccinate them. Well, welcome back. All right, you already know that I'm cranked up about this.
Yeah, it's going to be an episode.
It doesn't take much.
Forewarning.
But I'm Dr. Lloyd Finks.
I'm Shannon Finks.
And we have a very special guest with us today who I hope you will find as fascinating as we have found our friendship over the years. This is Dr. Stephen Foster. He is a pharmacist, a PharmD, as we refer to him. He's spent, 22 years now at the University of Tennessee?
Yeah. Yes, about 18 to 20, but part-time, full-time type of thing, yeah.
But before that, you have dedicated your entire career really to public health and served in the Indian Health Service, which is a branch of the U.S. Public Health Service.
Correct.
Yeah.
And then you also have a very fascinating story because you sat on the advisory committee for,
Immunization Practices.
Immunization Practice, ACIP. And you also are going to tell us, hopefully, and I'd like to hear the story again about why and when you left that, because I think it's very important. It's a very important part of this conversation. And I don't see how we're going to be able to do this in one episode. So I think we're going to do the same thing that we always do. Let's launch it here. And then if we need to take more time, we'll just do another episode. But we're going to talk today about the loss of trust in healthcare providers, and how that has played into decision-making in whether or not you're going to get vaccinated. And frankly, that's your decision. I get it. But this is why it bothers me. So let me just start off with this. This is the insanity of this conversation. You're making dinner. Unlikely, but you're making dinner.
Thank you.
And
you're so hard.
And you're slicing your onions, all right? And you cut yourself and you go, ow, and you come into the clinic. And routinely, we say, hey, when was your last tetanus shot? And we use it as an opportunity to ask, when was your last tetanus shot? Because if it's been outside of the last 10 years, we'd like you to get a booster. And you say, you know what, I think it's been more than 10 years. And I say, hey, I think you need a tetanus booster. And you go right ahead. Let's get that done. I think that's wonderful. I think that's absolutely wonderful. Let's stretch it out a little bit. Let's, evidence-based medicine. There's a dead bat in your child's bedroom. It could happen.
Wild.
Right?
Okay.
Wild bat. Yeah.
Wild.
Not a lot of us keep domesticated bats. But if there's a dead bat in your child's bedroom, and you're in the clinic, and we found a dead bat in the child's bathroom, and I say, yeah. So here's the deal. Even though you don't see a bite mark, and even though we don't know if that bat had rabies, chances are that you would benefit from rabies vaccine. And I think we need to start that right now. And you go, thank you, doctor. Thank you so much, whatever you need to do, because we don't want Lucy to have rabies, right? So that
you don't want Lucy to die.
I don't want Lucy to die.
Rabies.
I don't. And you don't want to have tetanus. And then I go ahead and you come in and you are here for your annual physical, Steve. And you check out perfectly. You're a heck of an example of a robust guy. And I go, hey, let's get your flu shot done. You go, do what? I say, well, what do you think about the flu shot? And you go, I don't think I want a flu shot. And I go, well, why not? And this just troubles me. How? What is the difference between me recommending you have a tetanus shot, me following evidence-based medicine that you get rabies treatment, even the chances bat bite is pretty slim, but you're going to argue with me about getting a flu. Where has this gone wrong?
I think a big part of this has to do with age. I grew up in a generation, you grew up in a generation, not Shannon, of course. We saw diseases. We had measles around, we had mumps around, we had rubella, chickenpox,
polio. Your friend.
Yeah.
Yeah.
And so all of these things we were actually exposed to. And so in order to prevent those, we had no problem. Of course, we didn't have any choice at that point. We were too young at the time. I mean, we were children, but our parents, who had seen the local community pool shut down because of smallpox and different things that occurred, polio, for example,
Sure.
they drug us in there when the new vaccines came out, and they made sure that we got it.
Yeah.
And so we grew up with vaccines.
And we grew up with the fear of those diseases. Because they were real to us.
Plus, how many times have
good.
you had the flu?
More than once.
Yes. And
Yeah.
you know how sick you can get.
Yeah.
Shannon's probably never had the flu because she's so young. So
This is your day today, isn't it?
Thank you.
but it's not hard to convince somebody my age to get a flu shot. It's very difficult to convince somebody in their 20s to get a flu shot. And so their perception of the disease, in fact, many of the diseases, we're seeing measles now, outbreaks all over the country.
Sure.
And it's because they've never seen measles, and so why should we get a shot for our kids when we've never seen measles?
Yeah.
We eliminated measles at one point in this country, and now it's back again.
Yeah. Yeah.
And so it's the generational exposure to the disease themselves that they haven't seen how bad they are. I mean, on the top 10 for the country, as far as the prevention of illness in general, vaccines like number 6. Clean water, I think, was number 1, but it's because they've done a tremendous job of eliminating disease.
Okay, let's just, for points of clarification, let's very briefly go through exactly what we're talking about in terms of a vaccine. And I think the history of a vaccine, we were talking earlier before we began today about the resistance to vaccination is nothing new. So start with Edward Jenner.
Well, Jenner came up with the he actually didn't invent it. He just spread it around, but the smallpox inoculation, where they took pus from somebody that had smallpox and stuck it onto a small cut onto somebody's body so that they would get a mild case of smallpox. And if you really think about the science behind that, somebody who had smallpox already had some antibodies built up towards it. So they actually had weakened that virus itself because of their own antibodies. So when they gave it to somebody, it was a weakened vaccine, if you want to call it that. So then that's what we do with our vaccines now, is that we take a disease, we either take the virus or the bacteria, we kill it, and then we inject it into somebody, or parts of it. We don't even inject the whole thing in anymore. We just take certain parts of it that we know that our body now will react to. And we want our body to react to it. In fact, when people say, well, it makes me sick, I go, good, because that's how we know it works.
Exactly right.
If it doesn't, you don't feel it or don't have any reaction to it, it may not be working.
Right.
So we take that part of it and we actually do that. Or we use a live virus, and that's not in too many vaccines anymore. It's in a few, but it's been tapered down a lot.
Like Flu Mist has a live virus.
But we inactivate it, and we do that by passing it through different tissues. And these different tissues, the virus weakens because it can't develop disease where it can actually spread. So it weakens. And then when it's weak enough that it can't cause disease anymore, then we give it to a person. And they have the reaction like they're going to have the disease to build up antibodies, but they don't get sick from it.
Okay.
And so that's how the vaccines work. So realistically, we're giving them the same thing that would cause the disease, but we've made it almost impossible to get the disease.
And there was a lot of resistance. You mentioned Edward Jenner, and I think his first work was with cowpox, which was a form of smallpox that was endemic in cattle. And he would take the pus, and one of the staff here, when we were just talking about this, said, "Ooh, I'm really glad that we upped the game on this. That we no longer, just make a small cut and put live pus in it." But as you say, what we do is we take the portion of that virus or bacterium and go ahead and create enough disease that we build immunity. And I think that's very important. People tell us all the time, "Oh no, I don't want to get the flu vaccine. The last time I got the flu vaccine, it gave me the flu." Yeah, it kind of did, but a very mild form of it, and you were better well within 24 hours. We gave you some Tylenol, and we presume that you now have the antibodies, or at least some of the protection that you need to fight off a full course of it. So you mentioned that you and I are older, and I think, look, this is well earned. But we've also seen some things happen. I believe if we're gonna talk today about why people are increasingly distrustful of the healthcare industry and of medical providers, then we need to start with, we've done some pretty darn stupid things in our past. And I will argue with you, Steve, and I'm pretty sure just looking at your face the way this is going to go. But I'm going to argue with you that we should be preventing disease that causes terrible morbidity and mortality, but I don't understand why we would continue just to stop disease. And therein lies the problem with the flu, because you don't know anybody that died with the flu.
Oh, yes, you do.
Well,
you absolutely do.
Well, you might now, okay, but the general public doesn't know anybody that died with the flu. And we certainly, when COVID started to come on board, and I'm going to, it's like I just entered the Salem witch hunt here because I said COVID. But when COVID started to come on board, it was even worse because people didn't even believe COVID existed. And we were proposing to vaccinate them.
So let's break down a couple of your passionate arguments here.
Was that passionate?
Yeah, that was a little passionate. One, we should utilize vaccines for morbidity and mortality. We should use vaccines for morbidity and mortality. And I think from a public health standpoint, that has always been the rationale for vaccination.
Well, let me comment on something. I wasn't disagreeing with you. I was actually more or less agreeing with you. What was not said in the introduction...
You need to work on your agreement face, by the way.
What was not said in my introduction is that I was on the Advisory Committee for Immunization Practices, which is the CDC committee that makes all the recommendations for vaccines. And I was on that committee from 2001 to 2021. So I saw all the development of vaccines in that time period and how they came about. And there is a calculation that goes into every one, which is called QALY, QALY, quality of age-adjusted life years.
Okay. Yeah.
And so they do factor in cost to society of the disease in that particular factor. That's just one of the factors.
Okay.
I mean, they take a lot of social factors. They take an acceptance of the vaccine. So there's a lot of objective stuff that they really try to put into a very subjective feeling population about that. So that part is still calculated into it. What has happened over time, though, is that the cost keeps going up. And there was a point where there was a cutoff of that number that says, no, it's not worth it anymore. And that number just keeps climbing. So it's really difficult to say where that's how helpful that is anymore. Because we made decisions on certain vaccines that it was not worth cost effective to do it for sure. Along with that, too, is that there's a lot of factors that go involved in these particular decisions to approve a vaccine or to make a recommendation. By the way, the FDA approves that the ACIP, which is the CDC branch, recommends it and passes the recommendations for it.
And then it becomes a guideline, or at that point,
right,
standard for the population.
And
not necessarily, though, an individualized decision. They're giving a recommendation for the public.
For the whole population, that's correct. So they got to look at the population. They can't look at individual. In fact, it's the difficult part is when we're sitting there, the patients we've taken care of, that does affect what we want to do with things too. So, but no, it's the general population that they look at it.
So let's throw out an example of where a population recommendation or a recommendation to the American public is a positive, but it affects someone as an individual very differently. So let's just take flu mist, because I threw out that it was a live vaccine. You cannot give a live vaccine, flu mist, to someone, or you should at least examine the risks associated with giving flu mist to someone who has an immunocompromised system. Correct?
Correct.
What I'd like to talk about is the hesitancy to follow a recommendation that is for the general population is not what a 20-year-old wants to do. They want to be able to sit down and examine the benefits and the risks for themselves and their particular health situation.
And if they could find a provider that would do that with them, then I'm sure that would be a great thing. But it's very difficult in today's marketplace to find a provider that'll take more than 20 minutes with you. And they're more interested in the pneumonia that you have than the prevention of the next disease. So that's the time factor that goes along with that. They're very busy.
Well, we find ourselves going back to these same themes with every one of these conversations, right? I mean, we practice reactive medicine rather than proactive. You mentioned pneumonia, so I got to treat your pneumonia. I don't, I really.
You say we, you mean the general insurance-based medical system is very much reactive.
I'm sorry. Yeah.
Not us at ZüpMed.
No,
Yes.
it's not, and that's what makes us different. And we have that advantage. We can talk to individuals. Really, I mean, this is a conversation that I wanted to go beyond ZüpMed. I think people know us. And I think people know that we have the time, we will take the time, we will listen, we will individualize our approach. I think that's all great. But again, I'm speaking and I introduced this subject on more general terms. And I think these more general terms are increasingly important. We have people that we strongly believe would benefit from the flu vaccine. We believe strongly that we have some people who would benefit from the COVID vaccine.
Absolutely.
All right. And yet we have people who absolutely refuse to have these discussions, even though they have the opportunity to have those discussions. They've already made up their mind. And so what I'm looking for here is a conversation, not necessarily specific to a certain vaccine, but why is it so different? I'm going to go back to the original. Why can I recommend a tetanus shot and everybody loves me? Why do I recommend a flu shot and everybody wants to burn me because I'm a witch?
But I would guess that you can really convince anybody to get a flu shot if you had the time to do it with them. Now, there are people that are what I call terminal anti-vaxxers. They're never going to take a vaccine no matter what. And you'll pick those people out and you'll say, well, I can try, and every time they come in, I'll say something to them, but it's not going to do any good. People trust healthcare providers if the healthcare provider will take the time with them. How many times
I disagree with you.
How many
Steve,
times
I'm
have
sorry.
you heard patients say, I went to see that doctor and he didn't even touch me. I'm not going back to see him again.
Sure.
That's right.
I understand that. But I also understand that these are changing and have changed times. I want us to spend a few minutes in talking about why we've lost the trust of the American public. I can't speak for the world public, but we've certainly lost the trust of the American public. And I want to talk about the evolution of people increasingly reaching for online information and not necessarily the old joke about Dr. Google. I'd be very pleased if somebody would read Dr. Google, but instead it's from Instagram and TikTok and all of these other social influences that we are seeing. So we can talk until we're blue in the face with a patient, but in the end, are they not going to, number one, distrust us? And number two, go elsewhere for their information.
Your original question was what changed? And of course it changed during COVID. I mean, the introduction of mRNA vaccines, the availability of both sides of the fence information online at your fingertips, the fear of the unknown, all changed healthcare. It changed.
I would take you back even further than that. I think it changed with measles. When Andrew Wakefield came out with the autism issue, and I don't want to dive into that because it's been totally debunked, but I think that's where it started.
Well, that is true. There was many parents. There were many parents who were concerned about autism, and that literature has been debunked. I think a solution which calmed parents' nerves was the ability to have an alternative sequence of pediatric vaccinations and to spread vaccinations out rather than giving so many at once. That's a solution for easing parents' minds.
But COVID did not help. You're absolutely correct. The way that when COVID first hit, it was scary to most people. I mean, here was this pandemic coming. We didn't know anything about it. We were seeing people die, and a lot of people died early on from COVID.
We all know someone who died.
Yeah, absolutely. COVID. And so it was scary at first. So and the government didn't know how to react to this, so they just shut everything down. Yeah, we can look back and say maybe these things that we did were not the best, but at the time, it was scary. People were scared. That's why there was no toilet paper on the shelf,
Right.
I mean, I'm laughing, but you're absolutely correct.
Right.
I mean, I'm one of the guys that bought some extra toilet paper.
The end result is no matter when it changed 20 years ago or just within 5 years ago, the end result is that we have a public now that distrusts the advantages or the benefits of vaccines, possibly across the board, even though some vaccines are if it's a deadly disease and they can relate to that, they have no problem taking it. But even the flu, yes, is deadly and can kill 20 to 60,000 individuals in a year's time, depending upon the virulency of the virus that's circulating. And we have healthcare workers today where we had over 90% vaccinated 10 years ago. we're only vaccinating 70 to 80% of even healthcare workers. So how do we solve this issue in a way that honors and respects patient decisions, and at the same time provide logical and reasonable advice as a healthcare provider to help them make that decision?
I mean, I'm going to tell you right now, I had a crush on Anthony Fauci.
Mm-hmm.
Okay, I still have a crush on Anthony Fauci, and I think the man was handed an almost impossible task, and I thought he handled it with grace. And Steve, to kind of echo what you said, I think we all make the best decisions that we can make given the situation, given the information that we have at hand. In retrospect, sometimes that information proves to fall to one side or the other of reality. But at that point in time, you can only make the best decision that you can.
An example with that I found out, there was a pharmacist friend of mine who in the public health service was actually an assistant surgeon general rank-wise, who actually was in charge of the response in the Congo with Ebola.
Mm-hmm.
And he said that was a breeze to take care of because the government stayed out of it. If the government would have stayed out of this one, in the way that they did, it would have been a lot easier to take care of too. He says he hates trying to fight disease in the United States because the government has to make the decisions on everything that you're doing. He said in the Congo, nobody wanted to be around Ebola, so they had full strength of what they could do. So as you mentioned with Fauci, he was put in a pretty bad situation.
Yeah, he was,
said.
and I also I'm listening to you talk. I don't know how else you can manage a nation this large and this populous in any other way other than a centralized government. I mean, unfortunately, you have to go ahead and have somebody that is doing something, right? Grateful Dead. Somebody has to do something. It's a shame it has to be us.
Well, it's not lost on me that
right.
Steve was on the ACIP.
And I quit.
And you quit during COVID.
I did.
So,
What motivated you to quit during COVID?
The advice of the healthcare providers on there was not being taken by the government. The government would, in fact, one of the ones that I remember is that they said that we're going to have this vaccine available for you. This was like in June. We're going to have this vaccine available on August 15th, and everybody can get this vaccine at that time. Well, normally, once the vaccine's developed, it goes to the FDA. Then it goes through months of discussion with the ACIP, and then the recommendation comes out. That vaccine was approved on August 13th by the FDA, which was the dating was just perfectly planned. The next day it went to ACIP, and the next day the CDC director signed off on it. By the way, this ACIP is advisory to the CDC. We don't make the decision. We make recommendations to CDC. But it was made at that point, and boom, on this exact same day they predicted it, it was happening. We really had very little input into that decision that was going on. And so the whole time during this thing, we were being told this vaccine's going to come out and it's going to be approved at this time. And it's just like, I thought, man, they don't need me on the committee anymore if they're going to be making these kind of decisions.
So who made the decision?
Well, I don't know who made the decision.
I mean, somebody.
Everybody was told what they're going to do. So
Sure.
somehow, I'm sure the CDC director was told they are going to approve that vaccine on that day. And it happened.
So we've lost the ability for scientists, physicians, pharmacists, PhDs to discuss around the table and make a solid.
Oh, wait a second. No.
Wait. Yes, because actually right at that same time, all the members of ACIP were told they cannot come back to the meeting because of COVID. All right, so we had to do all this through the video. Now, we got a lot of our connections and things that we did were after hours with this meeting. You'd meet with people, you talk with the things over. The government still, and I'm not an anti-government kind of guy, but the government still has not allowed these groups to come back together for the meetings.
Okay.
They still have to stay remote.
I can't speak for that. I can't speak for that, and I don't know whether this group is being dismantled, and I don't know the history of it, but I can tell you this. If this had gone another way, if this had gone the direction of Ebola, okay, an extraordinarily deadly, highly virulent disease, then you would all be looking at heroes in these various divisions that approved this vaccine within 3 days. Okay, as it turned out, it was a pretty bad virus, but it wasn't dramatic enough that people were dropping dead on this. But in retrospect, if you were to go ahead and if you had had a much different outcome, if you had actually measurably saved a lot of lives, I think history would have been kinder in this process of decision making.
That may very well be true. And I think with a few vaccines, common vaccines right now, where the public has lost trust, and maybe they shouldn't have lost trust because of our reactive, silly, slippery way that we took care of COVID. We did the best we could.
Oh, I don't think it was reactive, silly, or slippery. I mean, I think we did the best that we could under the circumstances.
But there were flaws. It was not perfect.
And let's talk about this for a second. We're not just talking about a schism that has formed in vaccines. We're talking about a schism that's formed in society. And it wasn't, I will argue it was before COVID. It was leading up to the election of 2016. And look, let's be honest, as a nation, we've been divided for a long time. It's what makes this nation work, right? Is our differences in opinion. But I believe that this black and white approach to everything that we do has been a function of our politics. It's been a function of our leadership. It's been a function of the internet and social media. We are increasingly becoming individual islands of belief. And I think vaccines just happen to fall into that category. So what are you going to do? I mean, they don't trust us. Well, look, let me clarify that.
I don't agree with that one.
Okay.
Yeah.
All right. So who trusts you? Do your neighbors trust you?
My family doesn't, but neighbors do.
Okay. All right.
No one trusts the prophet in their own hometown.
That's right. Yeah. No, actually, I get calls all the time from my neighbors asking what they should do.
Yeah.
If you have that connection with your patient, and if you have a patient in your practice, you have a connection with them. They're not there because they want to be there for no connections. They're there because they want that connection. You have that connection, and that's what makes your practice special. Even when I go to a chain pharmacy for a vaccine, I never once have seen a pharmacist come out and say to me, and you said you have, but I haven't, come out and say, did you get your flu shot today, or can I give you this? I've never seen that. But the minute I say to that pharmacist, I'm here for a flu shot, he takes me to the back room, and he'll spend 30 minutes with me if I have questions to talk about it, because he's given the opportunity to be unbusy at that moment and can take time with the patients. Yeah. And so the biggest thing is that you guys have built in your practice how you take time with people. Yeah. And I think that your advice means a heck of a lot more than the physician who's only given 20 minutes in his practice, and that includes writing the note, to come in there and take care of a whole patient. You can't do it in that time period.
Yeah, agreed.
I think one of the biggest gifts in this generation is knowledge at our fingertips. And so, as you said, you can look online and find answers to many of our questions. But you do want to have that relationship with someone who can walk you through what they're either reading to either, accredit or to debunk information. And I think that is the goal for the individual. Of course, we have government committees that make decisions and recommendations for the public as a general whole. But I think there are a lot of people who want our help in making those individual decisions for them. So let's just talk for just a second about COVID boosters right now. There are a lot of people who've had 12, 15, 17 boosters. And at what point does that end? And of course, the advantage of having immunity at that time or circulating antibodies is to reduce the risk of death and hospitalization. And I'm going to possibly be very comfortable recommending a booster to someone age greater than 60 with comorbidities, because they are higher at risk for death or hospitalization from the virus than someone who is an 18-year-old male, because let's be honest, I mean, it is a well-known fact that vaccination for COVID is not without complete risk. And there are cases of myocarditis that occur very, very rarely in the older population, but more commonly in young males, for example. And I want the ability to be able to talk a person through their decision to vaccinate for prevention for an illness that can be deadly still.
I want to say one thing about these decision-making things. The ACIP makes recommendations. There's really three types of recommendations. It's age-based recommendation, disease-based recommendation, or what they call shared clinical decision making. And shared clinical decision making means we talk together and you give me the pros and the cons, and we do, which is what you're saying.
Mm-hmm.
I would also venture to say that every vaccine is shared clinical decision making, because I'm not going to walk in and stick a needle in your arm without me talking with you about it first.
Sure.
So, I mean, there is some degree of that goes along with it. But you're right. I mean, the shared clinical decision making is what is liked the least by the committees, because they can't get the population to take it, period. Now, it could be because the physicians aren't recommending it, or the pharmacists aren't recommending it, or it could be the patient doesn't want it, or patients talk to his neighbor who's anti-vaxxer. So whatever the reason is, you have that. So they don't like that, because if I say everybody at this age gets this vaccine, then it's real easy for the provider to say, you need to get this vaccine. These decisions, like you're talking about with the age type of thing, partly is to stop the spread of disease among people who are more susceptible. So maybe a 20-year-old needs a flu shot so that he doesn't give it to his
grandmother, right?
Exactly. So there is reasons from that for the spread of disease.
Well, there's clinical reasons also, you guys, because if you look at the 1918 pandemic, who died during that period of time?
The young ones.
It was the young people with healthy immune systems who would get this robust response and drowned in their own secretions.
But also, the older people had been exposed to a flu virus similar to that in 1890-something, 95,
That's
96.
correct. Right.
And so they had some immunity built up, and these young people didn't.
Did not. I mean, it's a very difficult decision point to say you do or you will or will not benefit from this. And look, every decision that we make is risk versus benefit, right? You mentioned cost v benefit. And in today's world, insurance and although we don't take insurance at Zup, you can go someplace and get a vaccination and your insurance will pay for it, right? In today's world, the individual cost of that protection is relatively low. So you're only talking about the clinical risk of that protection. And the reality is, I believe in your former organization. I believe in the CDC. I believe in the FDA, because I ain't got nothing better to believe in. And I believe that those recommendations are really, truly based on what we believe is best for the individual.
Well, and those are brilliant people on those committees, you have to say, too. I mean, I'm not trying to shoot
if they
down
listen.
the
I mean, going back to your previous example, right? If
their advice is taken, right?
Yeah.
So you mentioned, Lloyd, that we don't file insurance. We are working on that, however, and hopefully soon we'll be able to announce some different changes with vaccinations. But I do
specific to vaccinations.
But I do want to just kind of reemphasize that we want patients to bring their questions. We want patients to come to us because we would rather talk a patient through the pros and the cons, and we want them to make the best decision for them, as well as the best decision for the population as a whole. Thanks, Steve, for being here with us today. I hope we also get a chance to maybe even talk more about specifics and come back at a later time and talk about
It'd be my pleasure.
those. Thanks for coming. And if you need a provider, if you need help with vaccines, if you want to talk with us more in-depthly about what makes sense to you and your family, to schedule an appointment, either go to our website, www.zipmed.com, or call us at 901-701-7010. Thanks, guys.